And we begin in private position. morning, everybody. And, first of all, apologies to our witnesses and our guests for the lateness of the start, and we do apologise for the delay. And can I thank the members of the House of the Oireachtas, both Senator Crown, who probably got no sleep, and members of the Dáil who had limited sleep. Thank you for being here this morning, and it does show that the importance of parliamentary democracy, that we continue and function, and I want to thank you all for making the effort to be here this morning. Could I, at the beginning, remind members and witnesses regarding mobile phones, and especially those near microphones and those in the public gallery, that mobile phones should be switched off for the duration of the meeting, as they interfere with the broadcasting equipment and also interfere with the staff. So even when they're on a silent mode, they do impinge on the quality of the broadcast and on the hearing of the sound personnel. I want to welcome everybody. In particular, I want to welcome members from the Irish Thoracic Society, the Asthma Society of Ireland, the Cystic Fibrosis Association of Ireland, the Alpha One Foundation, the Irish Sleep Apnea Trust, and also Professor MacDonald and Mr. Michael McGlynn. And I'll welcome everybody individually in a moment. Our meeting this morning has been at the request of Senator Crown, and I want to thank Senator Crown for highlighting the issue and for bringing us to this day, where our topic for discussion this morning is lung health promotion, and it is a very important part of our work programme. We had hoped to have it in conjunction with Ash Wednesday, which is the big traditional day of anti-smoking, but we took it in a wider context that's about lung health, as opposed to just talking about cessation of smoking, and that's the reason why we have it today. Before we commence, I want to remind people regarding privilege. Witnesses are protected by absolute privilege in respect of the evidence you are to give to the committee. However, if you're directed by the committee to cease giving evidence in relation to a particular matter, and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed only evidence connected with the subject matter of these proceedings to be given, and you're asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any person or persons or entity by name in such a way as to make him or her identifiable. And members are reminded of long-standing parliamentary practice or ruling of the chair to the effect that, where possible, members should not comment on, criticise or make charge against either person, either in the House or outside the House, or an official either by name in such a way as to make him or her identifiable. And with that, I want to again welcome everybody, and in particular at the beginning to welcome members of the Irish Thoracic Society, Ms. Suzanne McCormack, the Chief Executive Officer, and Dr. Edmund McKeown, the President. And Ms. McCormack, you're going to make the opening presentation, and you have up to 5 minutes of it. Dr. McKeown. Dr. McKeown.
Yeah, so I'd like to thank the Chair, I'd like to thank Professor Crown for inviting us here to speak with you today, and the Senators and the Deputies. I want to talk to you about lung disease. It's an extremely important public health challenge. The first thing I'd like to say is that lung disease is really any disease that affects the lung, any medical condition that affects the lungs. It includes conditions, as mentioned, that are related to smoking, such as COPD and lung cancer. But also, as you can see around the tables here, it also includes many other conditions that are not related to smoking, such as asthma, cystic fibrosis, sleep apnea and lung fibrosis, as well as genetic conditions such as CF and alpha-1 antitrypsin deficiency. The symptoms of lung disease are breathlessness, cough and wheeze, amongst others. And I think it's important to emphasise that breathlessness is an extraordinarily difficult symptom to live with. We look after patients that have severe breathlessness. They feel like they're breathing through a straw all the time. They're very disabled. They feel a sense of panic all of the time because of this sensation of breathlessness. And this is because of respiratory disease. And I think it's very important to emphasise the level of disability that takes place in the Irish population because of lung disease. Lung disease is extremely common in Ireland. 1 in 5 people in Ireland will die of a respiratory or lung disease. It is the second most common reason for admission to any acute medical hospital in the country, and has the second highest mortality in Europe is here in Ireland. If you go out to primary care, it is the most common reason for people to attend their GP, and the annual costs in 2006 were around 560 million. If you look over time as well about how have outcomes changed for people with respiratory disease, you'll see that there really has been no impact over the last 10 years. You compare that to our colleagues who look after people with coronary artery disease, who through a very concerted public health programme have seen a dramatic reduction in coronary artery disease deaths over 10 years, which is now less than that of respiratory disease. So what are the big challenges that face respiratory disease and that have led to a lack of public awareness of it and a lack of public policy that's led to try and improve outcomes for people with respiratory disease? Well, the first thing is a lack of awareness of the condition, both amongst policy makers and also amongst people who actually have the disease. And we recognise that the symptoms of lung disease, such as breathlessness, are often put off to other factors like not being fit or getting older, where in fact there's disease present. And so people present with quite advanced disease, whereby it's very, very difficult to treat and very difficult to recover lung function. The other issue is public perception of respiratory disease. People look at lung disease and say, this is all a lifestyle choice because of cigarette smoking. And as I've already said, the majority of lung disease, in fact, is not smoking related. And so public policy that impacts smoking, although we support it in every sense because it does impact lung disease, there are still a lot of lung disease that will not be affected by this. And outcomes in Ireland are already poor despite having relatively low smoking rates compared to other European countries where outcomes are better. The other issue, and I think this is very important to mention, is that respiratory disease is a disease of the poor. There's a 4 times higher incidence of chronic bronchitis in people who have a poor background. A 2 times higher mortality for conditions like pneumonia and COPD if you're in the lowest socioeconomic class. 4 times higher mortality for lung cancer and TB. ITS data that we collected on World Spirometry Day recently identified 1 in 5 people had abnormal lung function who never had a history of lung disease ever before. And of those, the 2 biggest predictors of whether they had lung problems was whether they smoked, which we expected, but also their educational level. People who never got an education level beyond junior cert had much lower lung function than those who got to leaving cert or beyond. And I suppose one other issue, and I think this is an important reason why we're here today as well, is that there really has been a lack of a clear message about lung disease in the past. There were 12 charities that were all looking after or focusing on different lung diseases with no cohesive message. But really in the last year we've come together as a group to form the Lung Health Alliance to try and promote lung health as best we can. And that's what we've been doing, and we've been doing this through the World Spirometry Day, to the Love Your Lungs campaign, and you'll hear a little bit more about that in a moment. I really just want to finish up by saying that lung disease is a huge public health challenge. It really has not been addressed properly, and we need to work together to try and develop a national public health strategy to try and improve lung health outcomes and increase awareness of lung disease. So thank you.
Thank you very much, Dr. McKeown, for your very interesting and sobering presentation, and thank you for your words. I want to welcome now from the Asthma Society of Ireland, Ms. Sharon Cosgrove, the Chief Executive Officer, and Dr. Basil Elisier, Medical Chair. And I'm not sure who's making the presentation. I think it's Sharon, is it?
Yeah, I'm going to start.
Very good.
Excuse me, I'm going to start off.
5 minutes.
Okay, thank you, Chair. Asthma is the biggest chronic disease that affects the largest number of the population in the country. We estimate that there's 470,000 people with asthma, and the Asthma Society of Ireland has been operating for about 40 years, representing people with asthma, providing information and education and services. And as Dr. McKeown said, one of the biggest challenges we have is education in terms of the patients, but also trying to advocate on their behalf to have the best possible treatment and guideline-based care in public policy and in the health services. We have an advice line, and we deal with patients, 2,000 patients every year. We have clinics, so we do what we can with the limited resources that we have available to us. We've no statutory funding at all for our core services for patients, so I just wanted to raise that at the beginning. But in terms of the numbers, as I said, 470,000 people in the country have asthma. It's the 4th highest in the world in terms of asthma. And we're the largest, or people with asthma are the largest chronic disease group in the country. 1 in 10 people have asthma, and from a children's point of view, 1 in 5 children have asthma in this country. So it's an enormous problem from a children's and a paediatric health point of view. One of the things to say is that asthma isn't curable. It's a condition of the lungs, which can be controlled and managed with correct medication and with education of patients. One of the tragic things is that 1 person per week dies of asthma in this country, and a number of those are young people. And we have contact from schools, from parents, from children who've lost friends to asthma, children who've been on sports day or on the field playing a game of football where they've caught their breath, they can't catch their breath properly, they have an asthma attack, and regrettably they've died. So these are preventable deaths, particularly in young people. So we'd obviously be very keen to advocate for a very comprehensive programme to be implemented to deal with this sort of thing. It's one of the conditions, one of the chronic conditions that can be very effectively managed in the main in primary care. 85% of the people with asthma can be managed in primary care. The remainder need more secondary care treatment, dealing with consultants and hospitals, and a number of those in both as a sort of shared service. We have 20,000 people attend A&E every year due to an asthma attack or an asthma exacerbation. The average length of stay is 3 days. 500 people require emergency nebulization. 50,000 people require emergency nebulization. And in terms of cost, something that isn't factored in is that adults with asthma miss on average 12 days per year from work, and children on average 12 days from school. So when you think about children and the impact that has on their education, on their participation in sports, and regular everyday activities, it's quite enormous. Children talk about the fact that they play sports, they run, they can't catch their breath, they can't participate in the same way as other children can. So children with asthma and people with asthma are affected day to day with very basic things like walking up the stairs or running for a bus. The things we'd like to advocate for and ask for, really from a public policy point of view, is that the National Asthma Programme, which was adopted by the government in 2011, is implemented. That there's a public drive or a politician sort of government drive to implement this programme. We need some impetus behind it to get it through, to get the resources at sort of primary and secondary care level to address these problems. The other thing that we wanted to raise was in relation to Xolair. It's a medication, a drug, which Dr. El-Nazir can go into in more details, that is for severe asthma patients. And there's inequity of access to it. It isn't covered by any of the reimbursement schemes, and it's identified in the GINA guidelines, the international guidelines for asthma, as the appropriate treatment for the most severe allergic asthma patients. So they're the two things we want to push for today, are the implementation of the programme and some type of action to address the fact that there's inequity of treatment. Spoke to a consultant yesterday who has 40 patients in CUH in Cork who can't get his patients access to this drug and who badly need it. Thank you.
Okay, thank you very much indeed, and we'll discuss that maybe more on the questions and answers with members in a minute. But thank you for your excellent presentation. I want to welcome from the Cystic Fibrosis Association of Ireland, Mr. Philip Watt, Chief Executive Officer, Ms. Caroline Heffernan. I think Mr. Watt is going to make the presentation.
Thanks very much, Kierlach, and thank you to public representatives after a very long night. I really appreciate you being here, and to Professor Crown, who facilitated the meeting today. I'd like to also welcome Caroline Heffernan, who's a patient advocate and a person with cystic fibrosis, who's with me here today. Cystic fibrosis, as you know, is an inherited chronic disease which primarily affects the lungs and digestive system of about 1,200 children and adults in Ireland. A defective gene causes an unusually thick and sticky mucus to build up that clogs the lungs and leads to life-threatening lung infections, and obstructs the pancreas and stops natural enzymes from helping the body break down and absorb food. Our association is the only national patient CF group in Ireland. We were formed in 1963, and this year is our 50th birthday, which is a fantastic achievement, along with the Irish Cancer Society. In the 1950s, very few children who had CF lived to attend primary school. And today, thanks to advances in research, medical treatments, and fantastic clinicians we have here, there is further enhanced and extended life for children and adults with CF. However, the disease remains very challenging. The median age of death is still around 25 years of age. But thanks to the good care standards in our hospitals, people with CF are expected to live into their 30s and beyond. And increasingly, some of our members are attending third-level colleges, accessing employment, and living in more independent lives with the support of their family. But this also puts major demands on adult CF services in particular, and there's a deficit particularly of adult CF services, also of children's services, but adult services in particular. As you know, Ireland has some of the most severe manifestations of cystic fibrosis in the world, and also has the highest incidence of cystic fibrosis in the world, with 3 times the rate of the United States and the European Union. So there's just a number of key points that we'd like to draw to your attention today. First of all is to acknowledge some of the recent improvements in CF care, but we are still catching up with accepted standards in the US and other parts of Europe. The recent approval of the groundbreaking drug Kalydeco, the introduction of newborn screening in 2011 for CF, and the long-awaited unit in St Vincent's Hospital are just some examples of very positive developments. However, huge challenges remain. For example, isolation facilities are still needed around the country, and there's an urgent need for 13 adult inpatient isolation rooms in Beaumont Hospital. There's only 4 there at the minute, and just some 130 adult patients. It's estimated that the costs of this project are relatively modest, 2.5 million for capital costs, but indications are to us as an association is we have to collect the money for that project through our fundraising, which is not entirely fair, I think, on the patients and their parents who have many other demands in terms of managing this disease. There are also major infrastructure deficits in many other centres around the country, which I've listed in our presentation. There's a need for an increased rate in double lung transplantation, and we're delighted to hear that this week there's been 3 such transplantations undertaken in the Mater Hospital. But we really need to double the present rate of transplants. Transplants are really needed at the end of people's lives, and it can make a major difference in terms of extension of people's lives and the quality of their life. So we would urge that there would be more transplants done in Ireland, and we acknowledge the fantastic quality of the transplantation that is undertaken. We'd also draw attention to the committee to the non-replacement or significant delays in the replacement of dietitians, specialised nurses and physiotherapists, which are affecting all the groups who are represented today. Those on maternity and sick leave are not being replaced, and that is causing real hardship for many of our patients. Annual assessments in some of our hospitals, which are vital for people's health, are being cancelled or deferred because of staff embargoes. We also object to the recent prescription charges for medical charge holders. That increase of 50 cents per item is up to a monthly limit of $19.50 per family, is causing significant hardships on our patients, but particularly because of the amount of medications that our patients need to take every month. We also need to preserve research funding and into new and innovative treatments, as the recent drug Kalydeco shows. And we would urge that the funding for schemes such as that operated by the HRB and the Medical Research Charities Group is maintained. And finally, the point that Dr. McCone made at the start of the presentation, the need for lung health in general to become a much more important public health priority than it is at the minute. That is very consistent from all the messages here today. It needs to be given a much greater priority. Also, practical initiatives such as greater emphasis on the flu jabs and also the vaccination for pneumonia, which is very important for vulnerable groups, but doesn't perhaps get very much publicity. The need for that are absolutely vital as well. And we'd call on partnership approach with NGOs working with clinicians through the Lung Health Alliance and the state as an effective way of going forward. Thank you very much, Ciara.
Thank you very much, Mr. Watt, for your presentation and for your words. And I want to welcome now from the Alpha One Foundation, Ms. Kitty O'Connor, Chief Executive Officer, and Professor Jerry McIlvany. You're very welcome. So
thank you.
Feel free to go ahead.
Thank you, Deputy and Senators, especially, as I said, in the night and the day that was in it. I'd like to welcome Professor Jerry McIlvany, Respiratory Consultant in Beaumont Hospital and also Chairman of the Alpha One Foundation. So briefly, I'm just going to give you an overview about Alpha One, the Alpha One Foundation, and our involvement with the Irish Lung Health Alliance and how important it is to us. And you might say to me, what is Alpha One? We haven't heard of this before. You might commonly have heard of this as hereditary emphysema, and that is Alpha One antitrypsin deficiency. But this is also a genetic condition. It can cause liver disease. The Alpha One Foundation was set up as a lung charity It's based in Beaumont Hospital, and that's the National Referral Centre for Alpha-1. And I know you've been given a lot of statistics this morning, but here's another one. 1 in 25 people in Ireland are carriers for this condition. And this makes it the second most common genetic lung condition in Ireland, next to cystic fibrosis. Alpha-1 is the fourth most common cause for lung transplantation in the world. And just to put this into the Irish context, the first single lung transplant and the first double lung transplant in Ireland was an Alpha-1 patient. Our research that we've done recently has showed that on this island of Ireland, over 3,000 individuals suffer with the severe form. But there's also 200,000 that also have a deficiency, and they're also at risk of lung disease if they smoke. A national targeted detection programme was established to test people with chronic obstructive pulmonary disease, or you might know this as COPD, poorly controlled asthmatics, unexplained liver disease, and first-degree relatives of Alpha-1. Early detection of Alpha-1 is vital, and it gives us a real example of how personalised medicine in this age can come and yield improvements in quality of life, life expectancy, and smoking cessation. And to date in our programme, we've screened over 10,000 individuals. 300 of those have had the severe deficiency, and 2,000 have had a milder form. 26 different hospitals participate in this programme, so we feel it's vital for the maintenance of this target detection programme. And just how we became involved with the Irish Lung Health Alliance, we decided that we wanted to highlight lung disease in Ireland. So we joined up with other groups, patient support groups and health professionals. There was 12 of us in total, and this gives us a unique partnership with all these key stakeholders in lung health. Its key messages are the same as ours: early diagnosis, early intervention, and increased awareness of lung health. We've found we've benefited from the involvement and membership of this group. And last year, you might have read something about the Love Your Lungs campaign, where we had Dr. Ronnie Delaney supporting our cause. And this was aimed to highlight that lung disease can affect all people, all socio-economic groups, non-smokers as well as smokers. We encourage people who had symptoms like cough, wheeze, shortness of breath to get a simple free lung test. In this way, the same way as you can get a blood pressure measurement done, you can get a simple lung test done to see if you have any lung disease. This campaign highlighted the fact, as Dr. McKeown has said, that lung disease is highly prevalent and underdiagnosed in Ireland. The Irish Lung Health Alliance wants to involve all stakeholders in lung health and give a voice to hundreds of thousands of patients suffering with lung disease. Our main aim here this morning is to highlight the fact that we would like to be the contact for government in efforts to raise awareness for lung health and its importance in formulating future lung health policies. And thank you for your time.
Thank you very much indeed, and for your interesting statistics which we didn't aware, which I wasn't aware of until I read your presentation for today, but thank you. And I want to know, welcome from the Irish Sleep Apnea Trust, Mr. Dan Smith and Mr. Arthur O'Hara. You're both very welcome, and Ms. Smith, you're going to make the presentation.
Thank you very much, Chairman. Just initially, the Irish Sleep Apnea Trust was formed in the year 2000. We're completely non-profit volunteers, and we receive no state funding. First of all, I'd like to go through what is sleep apnea. Sleep apnea, we spell it the old Greek way, A-P-N-O-E-A, and the Americans spell it N-E-A. It's a respiratory sleep disorder where the sufferer frequently stops breathing while they sleep. Breathing cessations last for at least 10 seconds and may be accompanied by a drop in blood oxygen saturation levels or even a cardiac event. The name sleep apnea is derived from apnea, a Greek word meaning without breath. It's a very serious medical condition which in its severest form can cause premature death. There are three main types of sleep apnea. We have obstructive sleep apnea, which is very much the most common. It's caused by an obstruction or a collapse of the airway. We have central sleep apnea, which is a neurological condition where basically the brain forgets to tell the body to breathe. It's very serious but very, very rare. And then we have a mix of the two. Severity of the condition is measured by a thing called the Apnea-Hypopnea Index, an AHI, which in effect is a cessation of breathing. So anything within a range of 5 to 15 times per hour is mild, 16 to 30 is moderate, and above 30 is severe. That's stopping breathing 30 times during your sleep every hour. There's very serious health risks, obviously. We have excessive daytime sleepiness, which leads to poor work performance and a high risk of road traffic accidents. We have an increased risk of cardiac disease and stroke, increased risk of diabetes, and increased risk of glaucoma. The symptoms include severe snoring, hypertension, diabetes, severe mood swings, excessive daytime sleepiness, impaired cognitive function, impaired short-term memory, and a thing called nocturia, which involves frequent bathroom visits during the night. Treatment is very simple. It's by way of a device called continuous positive airway pressure, called CPAP, which basically splints the airway open by an airflow which is set at a particular pressure. There's also a device called an oral appliance, which is made by a specially qualified dentist, which draws forward the lower jaw, and that has proved effective in dealing with mild and possibly moderate apnea. To go through the numbers, population studies carried out in the 1990s indicate that 4% of the adult male population and 2% of the adult female population suffer from sleep apnea, and 0.5% of children suffer from sleep apnea. Now, more recent studies indicate that up to 10% of the adult population and 3% of children suffer from sleep apnea. In the case of children, there's a very close link to children with Down syndrome. 45% of them are likely to develop sleep apnea. So basically, the figures are looking in the 1990s studies of up to 112,000 sufferers in Ireland, and it could be as high as 360,000. So if we take a best case scenario, there's a significant number of people in Ireland with the condition. The large increase in the number of children suffering from this condition is a major concern. Moving on, I'd like to take this under two headings. One is sleep apnea in adults and the other under the paediatric area. The current position in Ireland is that a number of health service executive managed and voluntary hospitals offer a type of an ad hoc service. There's no structure to it. There's no national structure or framework for dealing with the condition in the public health system. The type of service offered varies from hospital to hospital, with only one HSE hospital offering dedicated sleep disordered beds. In many cases, diagnostic testing is suspended when an acute hospital finds itself busy, usually through a busy night in A&E. Typical of this is a current problem in Dublin, where possibly the largest unit in the country at St Vincent's University Hospital has its staff reduced and is facing the prospect of a vastly reduced service from June of this year. They're looking at halving the service, basically. ISAT have met with the CEO of the hospital, who has no money, and the HSE have not responded to correspondence. Beaumont Hospital, and there the sleep disorders unit is located in St Joseph's Hospital, Raheny. And I might add that the public unit there was funded by private sources. It's been closed since mid-December last, as there's a perceived safety issue. I don't know what it is. Since sleep studies have been suspended there has been a situation where up to 100 patients are left in limbo. There are similar problems throughout the country. It should be pointed out there are no sleep medicine consultants employed by the HSE. In Ireland, the diagnostic work is carried out by respiratory consultants who give up a percentage of their time to deal with this condition. There are many clinical studies available which prove that sleep apnea patients who are being successfully treated are less likely to develop cardiac conditions, are up to 33% less likely to get a stroke, and usually have fewer visits to their GP. ISAT have pleaded with two health ministers to introduce a national strategy to deal with this problem, to no avail. Only recently, and this is this year, the Road Safety Authority has issued new guidelines to general practitioners on fitness to drive, and this is for Group 1 drivers. On page 56 of this document is a section covering sleep apnea. It states that drivers who suffer from symptoms and are sleepy must not drive and must report this to their driving licence authority. GPs are not qualified to diagnose this condition, and with an ad hoc sleep disorder service whose capacity is being reduced, we fail to see how these regulations can be enforced. Particularly if a suspected sufferer of sleep apnea may have to wait up to 12 months to get officially diagnosed and then has to wait further to get treated. It is an absolute must that a national strategy be introduced. I want to go through children, sleep apnea in children.
Briefly, do you can, please.
Pardon?
Your 5 minutes have elapsed.
Oh, has it?
Yeah, but go on, you go ahead.
Could I just
You can, of
finish
course,
off
yes.
here?
Yes,
okay.
go ahead. Yeah.
Sorry. The situation with children with sleep apnea is even worse. Sleep apnea in children is a very different condition to that in adults. It is frequently associated with conditions like ADHD, and approximately 45% of children with Down syndrome are likely to develop the condition. There is no structure at all, with a number of hospitals offering ad hoc services. There are no sleep consultants employed by the HSE. As with adults, a number of respiratory physicians coupled with respiratory scientists offer very limited services. The following hospitals offer some degree of service. We have Our Lady's Hospital for Sick Children in Crumlin, Temple Street Children's Hospital, Adelaide and Meath in Tala, Cork University Hospital, Galway University Hospital and Midwestern Regional Hospital. We believe that paediatric units in Mullingar, Cavan and Drogheda have shown an interest. In many cases, these centres cannot offer the full overnight sleep test called a polysomnogram and rely on the less reliable oximetry test. To give an idea of the scale of the problem nationally, in 2007 there were 433 tests carried out, that's polysomnograms and oximetry, in paediatric units. In 2011 there were 1,793 tests carried out, that's an increase of 414%. The number of children on non-invasive ventilation increased by 627% over the same period. Waiting times for oximetry testing are in excess of 8 months, and waiting times for polysomnograms are over 12 months. It's no way to treat our children. A national strategy is required, whether it be done jointly or severally. It is a must. And I won't go any further on this.
No, go ahead, you go and finish your presentation.
Okay.
Yeah.
Just to summarise, the diagnosis and management of sleep apnea is something that cries out for an introduction of national strategy, both for adults and children. From an adult perspective, the introduction of fitness to drive guidelines for Group 1 motorists places additional pressure on what is a fractured clinical service that has been starved of resources over the years. The proposed introduction of fitness to drive guidelines for Group 2 drivers next year will create an even bigger strain on the service, as it has been proven by a number of recent studies that the incidence of sleep apnea in professional drivers is as high as 28%. Taking this perspective alone, there is an undeniable case for a national strategy to deal with sleep apnea. After all, these guidelines have been introduced by a national regulatory body, and as a nation, these decisions must be supported. From a children's perspective, it is even more serious. To have a situation where we continue to ignore the plight of up to 3% of our children is unacceptable to ISAT. And I suggest to the people of Ireland, there is an absolute no excuse for it. With the use of modern technology and committed people, the cost factor of a national strategy can be controlled. Thank you.
Thank you very much indeed. And could I just ask one question in the context of Beaumont Hospital, in the context of St. Vincent's? The HSE have not responded to any correspondence.
I got no response from them.
And when did you last?
It's about 3 weeks ago, 4 weeks ago, yeah. I have had a response on Beaumont, all right.
You have on Beaumont?
Yeah, but it's kind of kicking for touch.
Okay. If the meeting is agreeable, I would propose that we would write to the HSE to know why they haven't responded back. Is that agreed? Yes. Okay, Gramad. Thank you. Okay, thank you. And finally, but not least, I want to welcome and thank Professor Tim MacDonald, who is the National Clinical Lead for COPD, which is the Clinical Strategy and Programme Directorate, and also Mr. Micheál McGlynn, the Chair of the Support Ireland Group. So, Professor MacDonald, the floor is yours.
Thank you very much, Chairman. I'd like to echo my colleagues' thanks to the Senators and TDs for having us here today, and particularly to Senator John Crown for inviting us or organising the invitation. I suppose to start off with, I have a problem in that most people don't know what COPD is. Chronic obstructive pulmonary disease is a disease associated with narrowing of the airways, and this leads to the patient having two problems primarily. One, a difficulty with breathing, and secondly, a propensity to getting infections or exacerbations in the symptoms, which may lead to them seeking medical care either through the GP or attending hospital. And these are patients who are very numerous. They end up in the winter time, during the winter trolley crisis, producing a lot of patients that end up on trolleys, and if you like, contributing to a lot of the difficulties in the AED departments that we're well aware of. The confusion with the disease is, I guess, is it asthma? And the name is a difficulty for patients. A lot of patients who I deal with who've got COPD will tell me they've got asthma, they'll tell me they've got COAD, they'll tell me they've got smoker's asthma, all these sort of things. It's different from asthma. We've heard already from my colleague about asthma, and asthma tends to be associated with younger patients. It tends to be more reversible. COPD is a progressive disease. It tends to get worse as you go through life. So it is different, and it tends to affect a different spectrum of the population. The diagnosis is on the basis of a simple spirometry test. It looks at the airflow reduction, and basically that can be easily available, but unfortunately isn't. It's only available in perhaps 50% of GP surgeries, and that is certainly a problem. How common is it as a disease? It's certainly very common. We've heard a lot of figures here today, and a lot of the problem we have in the Irish healthcare system is actually providing accurate figures. But we reckon there are about 100,000 patients in the country diagnosed with COPD. There are perhaps 200,000 more who don't have the diagnosis made. It's a disease that's becoming more common with increasing age. We reckon that from Canadian figures, that about 1 in 4 people who reach the age of 70 will need treatment for COPD. In terms of things that we can count, we know there are at least 12,000 admissions to our hospitals each year with COPD. There are probably more, but 12,000 directly related to COPD. We know that unfortunately 1,400 people die a year from COPD. To put that into perspective, we know that 1,400 people approximately die from lung cancer, which we now know is the biggest cancer killer in the country. So it's a huge cause of morbidity and mortality in patients. It's probably the most frequent cause of patients with chronic diseases being admitted to hospital, and the frequent cause of readmissions to hospital. Many of my patients with COPD have had multiple admissions to the hospital, and when you take it that the average length of stay for patients in hospital has been around 9 to 10 days, it does involve them being in hospital quite a considerable period of time. What causes it? It's predominantly caused by smoking, but not all cases are related to smoking. Other factors we've heard already that alpha-1 antitrypsin can contribute to it, that people who are born premature can have a difficulty with it. It is associated with deprivation, and it does tend to perhaps reflect poor nutrition, things like that. But unfortunately, smoking is a big factor in it. A lot of the patients that have it are ex-smokers. So you can stop smoking and 10, 20 years later have done enough damage to your lungs that you present with COPD. So it's not fair to sort of say it's smokers and they should stop smoking, that's the end of the problem. These are people who've chosen to give up smoking, a lot of them, and are still afflicted with the disease sometime later. I guess, as I started off in the presentation, the issue is why is there so little public recognition for it? Well, the name is a problem. We've heard already about bronchitis and emphysema. COPD is pathologically bronchitis and emphysema, so it's kind of a catch-all phrase for chronic bronchitis and emphysema. It's difficult for patients to remember COPD or chronic obstructive pulmonary disease. The disease takes decades to develop, and patients sometimes attribute the symptoms to basically getting older. You know, I'm short of breath because I'm getting older, whereas in fact you're short of breath because your lungs have got damaged. It's more common in the poorer social groups, and I don't need to tell you that the poorer social groups tend to get poorer health care and poorer solutions to their problems. The chronicity of the disease is associated with some degree of guilt. Perhaps, you know, the issue of smoking tends to make people less likely to demand resources for it, and people who've got used to the disease developing slowly just don't go looking for resources for it. And I have to say that amongst our colleagues, and indeed myself, I didn't do respiratory medicine to look after COPD patients. I was more interested in more exciting ends of respiratory medicine, but I ended up doing COPD. And basically, there's this nihilism that has been a part of the problem up until very recently. Doctors, nurses weren't really interested in looking after COPD, and that's reflected the public mood. I think that's changing for the good, and initiatives like the Lung Health Alliance and the Irish Thoracic Society are certainly pushing the agenda on this. But there has been, both in this country and other countries, a lack of awareness and a lack of interest in dealing with this problem. And to date, we've heard about various patient advocacy groups here today. There isn't, as of yet, a properly formulated group to support COPD, which is a huge number of patients. Mr. McGloin, who's travelled down here this morning from Sligo, is the chairman-elect of COPD Support Ireland, which is in the process of being formed at the moment. But that is a